Thank you very much, Rinat, and thanks to the organizing committee for inviting me to speak. I've taken the liberty to shorten the title to Chemotherapy and Cardiotoxicity in Breast Cancer. I have no disclosures. Since I'm sure there are many non-oncologists in the audience, I thought it would be helpful for just a couple of minutes to review how we treat breast cancer and why chemotherapy-induced cardiotoxicity is certainly a major issue. As you see, in the USA, we expect 230,000 odd cases of female breast cancer in 2015 with a mortality of 40,000. It's the most common cancer in women in the US, Israel, and Europe. In Israel in 2012, there were over 4,000 new cases of breast cancer. The incidence is higher in Jewish women than in Arab women, although the incidence is increasing and the difference is narrowing between the incidence in Jewish women and Arab women. Almost 1,000 women died in 2009. And two important facts relative to cardiac follow-up. 5-year survival, as we've seen early this morning, is getting better and better. And the 5-year survival of women diagnosed in the early 2000s in Israel is 86%. And also, the majority of women who have this disease are over 50. Breast cancer is normally staged. What's important to us is how much the size of the tumor in the breast, the draining lymph nodes. But what has become even more important has been dividing breast cancer into phenotypes by their expression, first of all in light microscopy by certain immunohistochemistry proteins. So it's important to us to divide breast cancer to these four main types: luminal A is the majority, luminal B, HER2 positive, and the triple negative, which are negative for all of the receptors. This is sort of an illustration of that. You see in the top horizontal pattern just an example. Luminal A, the first picture in the upper corner there is the H&E, regular H&E preparation, and then we see stains respectively for the estrogen receptor, the progesterone receptor, and the HER2 receptor. And the most common type, luminal A, the HER2 is blue, meaning nothing is staining, and the ER and the PR are positive. The luminal B has different definitions. I won't go into the variations, but it can be HER2 positive. It's often, and it's more aggressive than luminal A. HER2, we see it's negative for ER and PR and positive for HER2. And the basal-like, sometimes known as triple negative, is negative for all of them. So what's the molecular basis for that? What's interesting in work first done by Peru and North Carolina in 2000 and then pursued by many others over the years, we can see that breast cancer, when you evaluate the RNA expression of large numbers of genes in the tumor, you can group them into groups on a molecular basis, and much to our good fortune, about 90% of the grouping corresponds to the immunohistochemistry staining of ER, PR, and HER2. What you see here along the vertical are about 150 genes, and each horizontal line is a separate gene. There are about 150 genes on the vertical axis there. And along the horizontal axis are many different tumors, and with the red being expression and green being less expression. And we can see that they can be grouped pretty well, which is fortunate because it's still unwieldy to try to do a molecular analysis of 150 RNA expressions on every single breast biopsy you do, but it certainly is practical and is standard care at all hospitals to do immunohistochemistry staining for the stains that I've mentioned. So what's the treatment now that we've diagnosed breast cancer? Usually surgery is a very important part, either lumpectomy or mastectomy. We try to preserve the breast when possible. There's certain indications when it's not possible. It's usually important to sample histologically the lymph nodes. We do a sentinel lymph node biopsy, and sometimes there's indications to do a more extensive axillary dissection. And of course, radiation therapy is an important part. When lumpectomy is done, most of the time radiation therapy is given to the breast, and there are certain indications for radiating the nodal area. What about systemic treatment? As a result of a rich history of clinical trials from dating back 40 years and more, we now give adjuvant systemic therapy to the great majority of breast cancer patients. Sometimes we give neoadjuvant therapy, which is systemic therapy to non-metastatic breast cancer, but before the local therapy with surgery. So we'll just group them together as adjuvant or neoadjuvant therapy. We give endocrine therapy, things like tamoxifen and aromatase inhibitors, to patients who are ER and or PR positive. We give anti-HER2 therapy, usually Trastuzumab and often Pertuzumab, to those patients who are HER2 positive, either in an adjuvant fashion or both a neoadjuvant and adjuvant fashion. And finally, chemotherapy is given to virtually all patients who are HER2 positive, in addition to their Trastuzumab and Pertuzumab, just about most triple negative patients, and many ER and PR positive patients, depending on the recurrence risk estimation, for which we have quite a few tools these days to try to evaluate. What are the drugs that are used in the adjuvant and neoadjuvant chemotherapy? That's the subject of what we're discussing in these few minutes. Of course, doxorubicin, which is Adriamycin. Doxorubicin, in most modern protocols, for breast cancer, in adjuvant therapy, we go up to 240 or 300 milligrams per meter squared cumulative dose, and usually not more. Epirubicin, a doxorubicin analog, which may or may not have less cardiotoxicity in the same therapeutic effect range. Cyclophosphamide, the taxanes, as I mentioned, Trastuzumab and Pertuzumab for HER2 positive, and somewhat less these days, 5-FU, although still in Canada and Europe used a lot, and methotrexate just in certain circumstances. And of course, combinations are given. It's rare to give a single agent, but that's beyond the scope of the talk. I think you're enough expert now in breast cancer that we can go on. Many chemotherapy agents are used in addition for treatment of breast cancer in the adjuvant setting, in the metastatic setting. First of all, we can use all the same drugs that I just mentioned. Certainly, there are certain indications for when we feel that it's reasonable to repeat a drug. Are there clones that are resistant to a drug that was given? So we often don't quickly return to the same drug. But additional drugs that are approved for use, either Europe, USA, Israel, or all three, are this list here. Now, what happens to the heart? There was an excellent review by Lennon and Cardinali, that's Daniela, who was referred to earlier today. What are the late cardiac effects of cancer treatment? Published in the Journal of Clinical Oncology, and I don't have to tell this audience here, and we've heard some of it this morning, whether it be vascular, structural, but probably most relevant to chemotherapy, myocardial dysfunction and heart failure, which we'll talk about in a moment. And of course, we'll hear later from Professor Yachalom about the radiation therapy aspect. What about doxorubicin? First of all, just a sort of a sidelight. Adriamycin is actually a trade name, but it's a trade name that I don't think exists anymore, the original company that manufactured it. So although I make an effort never to put trade names in talks, I think since nobody makes it anymore, I can do it. And the mechanisms of toxicity we've already heard about today. In general, topoisomerase 2 is inhibited. There's also free radical formation. But to the best of my knowledge, most of the work has shown that the cytotoxicity that's relevant to levels that chemotherapy can get in cancer cells, it's actually more the topo-2 inhibition that may be more important. And as you know, that's the enzyme that's involved in enabling DNA to unravel so that it can duplicate and then to get resealed. There are various theories on exactly what the mechanism is of doxorubicin-cardiotoxicity, and people have alluded to it today. If you look in PubMed, people are publishing constantly, so it'd be interesting to see what work eventually shows is the basic cause, but in general, it probably still involves free radicals formed by the reduction of doxorubicin in the mitochondria, leading to apoptosis and cell death. And because there are a lot more mitochondria in cardiac cells than in cancer cells, that becomes a more predominant mode of action. The clinical presentation that we see, very unusual to see acute arrhythmias, or certainly symptomatic arrhythmias. I remember when I was a resident in internal medicine in Pittsburgh in the late 1970s, we used to transfer to the ICU for cardiac monitoring every patient who was going to get Adriamycin. Now that's a far cry from today, when every outpatient oncology and hematology department administers Adriamycin to many patients a day. And of course, like others, we called it the Red Death. But things are different now. We understand it a little bit more, and we're certainly learning to cope with the problems. So chronic cardiotoxicity, starting with asymptomatic diastolic and systolic function, progressing to heart failure, certainly is the big issue today. The early studies in oncology showed that there was a risk of heart failure arising with cumulative dose. The early studies showed increase at only 550 milligrams per meter squared. But of course, that was before the era of modern testing and monitoring techniques. So you see some of the percentages here that I took from the literature. Of course, if the patient has the well-known cardiac risk factors, that increases the risk. And one of the references is, of course, Professor Yahalom's chapter in the standard textbook of oncology about cardiac risk in cancer treatment. What are our options as oncologists for reducing cardiotoxicity? Well, we can limit the dose to 300 milligrams per meter squared, which probably has reduced toxicity. It's been shown that when we give Adriamycin in more frequent doses, in lower doses, it can be less toxic. I right now have several patients with metastatic disease who are doing very well on weekly doses of doxorubicin with minimal toxicity, also the acute toxicities that are more bothersome generally to the patient. In certain diseases, continuous infusion was found to be associated with less toxicity, but that's not, I believe that in the pediatric group, that's not been shown. And again, the question, do certain anthracycline analogs, such as epirubicin or metronidazole, is that helpful? And it's not clear that those drugs really improve the situation. Administering with, as we've seen in Hadassah's presentation, perhaps dexrazoxane, and administering a liposomal formulation, which I'll elaborate on a little bit, or maybe just frequent monitoring is what's important. But of course, we've heard that there are still things to be proven in that. What is dexrazoxane? It's a drug that we give that chelates intracellular iron in the myocardium. It prevents the generation of free radicals by preventing formation of anthracycline complex. It's indicated for use, so over 300 milligrams per meter squared of doxorubicin given, approved both in the USA and Israel, and I would imagine in Europe as well. There are still some lingering concerns about reducing, whether this reduces doxorubicin efficacy in curative treatments such as adjuvant treatment for breast cancer, which is one of the reasons why it was never approved for less than 300, for somebody who's had less than 300 milligrams per meter squared cumulative dose. One of the most exciting things was a product of I would say, of Israel. Professor Alberto Gabizon of the Hebrew University and Director of Oncology at Shaarei Tzedek Hospital has been instrumental for over 30 years in work on the development of liposomal encapsulation of cytotoxic agents, the most important of which was doxorubicin. He recently has presented data on another drug, mitomycin C, being encapsulated. And the encapsulated doxorubicin was developed gradually, first a non-pegylated type, this drug here, and then finally the type used today, the pegylated encapsulated liposomal doxorubicin, trade names Doxil and Kalex, and there's also another trade name of a generic brand in the USA. There is a polyethylene glycol coating over the lipid layer, and all of this enables the drug to stay in circulation longer, although at a lower level, and not have the peak. And in addition, the drug is basically concentrated preferentially in the tumor and taken up much less by the other tissues. Now, this has actually a lot of advantages to the patient, and not just in the cardiotoxicity. We have found that there is less myelosuppression. There is, with the pegylated liposomal doxorubicin, less myelosuppression, less nausea and vomiting, virtually no hair loss, and of course, the issue with cardiotoxicity, there seems to be much less cardiotoxicity. So this is certainly a promising direction. Another drug that's used a lot, that's very important in terms of cardiotoxicity, is Trastuzumab, the anti-HER2 monoclonal antibody, which revolutionized the treatment of HER2 overexpressing breast cancer patients. This toxicity probably is a result of HER2 expression on cardiomyocytes, which are required for normal heart development. And what's interesting is that this is, first of all, not dose-dependent, and has been pointed out before, is reversible. It's a type 2 cardiotoxicity. Essentially, the ways that risk reduction has been done is by avoiding giving it with doxorubicin concomitantly, because some early trials gave it together and did find that the toxicity was quite substantial, and monitoring the LVEF, which is clearly not evidence-based, but we certainly do it a lot. There are 4 major trials in the world that evaluated Trastuzumab as an addition to standard chemotherapy in HER2-positive breast cancer, which quickly showed the advantage. We in Israel participated in 2 of them, and in one of them was Dennis Sleiman's trial, the BCIRG 006, which was a comparison of standard Adriamycin Cytoxan docetaxel chemotherapy with the same chemotherapy plus Trastuzumab, and with another combination using carboplatin instead of doxorubicin along with Trastuzumab. And this was published in the New England Journal with a 65-month follow-up. One of the other trials that we were in, the HERA trial, has even longer follow-up, as we heard this morning. But what's particularly interesting about the Sleiman trial is that there was very careful control of the original chemotherapy. In the HERA trial, we could give any chemotherapy within a certain range that we wanted. So here, this trial is a little more clear what doxorubicin did or not. So the important thing is here, first of all, in the 5.5 years, there was 0 cardiac deaths in any arm, over 1,000 patients in each arm. And there are very few cases of overt congestive heart failure. A few more, in fact, even in the Trastuzumab arm, of just 2%. And we see that the elevated LVEF the decrease in LVEF was seen mainly in the combination arm, but again, the rates were fairly low, and as this will be followed up, probably will go down. But in any case, what we see is that the actual contribution to LVEF decrease, we don't know whether it's the combination of Adriamycin and Trastuzumab or Trastuzumab alone, but I think the message of this slide is that the risk is fairly low, at least in the first 5 years, and that certainly one of the ongoing themes has to be that primarily we have to treat the patient's cancer and at the same time try to protect their heart, but don't start off with protecting the heart and then maybe try to get in the chemotherapy. I'd like to close with just a mention of some of the other drugs that are used in breast cancer therapy. First of all, Capecitabine, an oral prodrug of 5-FU, has become a very popular drug both among oncologists and patients because it's fairly easy to give and easy to take and keeps the metastatic patient out of the clinic and the infusion unit more. About 3 or 4% or more of patients can develop the syndrome, angina pectoris, acute MI, probably because of coronary vasospasm. I recently had a patient like that who's in fact a HER2 positive patient who had exhausted most of her HER2 lines. So I put her on this, and she's a young woman in her 40s, and then every now and then she had some chest pain, which may or may not be related, but we think it is. The taxanes are interesting drugs and important for breast cancer treatment, but probably have turned out to be a lot less of a cardiac problem than originally was thought. In paclitaxel, the most common one and the oldest one, can cause bradycardia and hypotension, but usually that can be handled, but it's quite unusual. Docetaxel, sort of in a related toxicity, causes fluid retention by capillary leak syndrome, but steroid prophylaxis prevents that. And a newer drug is nab-paclitaxel, which can cause chest pain and thromboses, but again, unusual. Cisplatin and carboplatin are fairly old drugs now, but they're coming into vogue again in breast cancer. These are DNA damaging agents, which probably have a special effectiveness in tumors that are BRCA deficient, which are probably both in mutation carriers of BRCA, but also in patients with triple negative disease who have disease, who probably are somewhat deficient in BRCA in their tumors. In any case, these platinum agents sometimes can cause a microangiopathy, which could lead to MI and CVA. We have a lot of experience in oncology in general with platinum, and the interesting experience cardiac-wise, in my opinion, is with the young patients with testicular cancer who generally start out not with very many cardiac risk factors, and then we see sometimes early age MIs and other complications. And we'll be hearing about lapatinib and tyrosine kinase inhibitor, a small molecule, and these a member which we often use in breast cancer, usually as after exhausting a number of lines of Trastuzumab and Trastuzumab-like treatment. Whether the QT prolongation is clinically important, I'll leave that to the cardiologist to tell us. And finally, the last drug, a drug that is of common use and accepted in part of the armamentarium and colon cancer and other tumors, but is sort of trying to find its place in breast cancer. Probably in some cases of metastatic breast cancer, it's an important drug, a monoclonal antibody against vascular endothelial growth factor. And here, we, the oncologists, have to learn, or some of us who once were internists have to relearn how to treat hypertension. It's a fairly common problem, but we certainly don't want to stop every patient on Bevacizumab because of hypertension. More serious issues can occur, such as stroke and so on. This is where I come from. This is Soroka Hospital in Beersheba. One of the advantages of working and living in Beersheba is that we're just about 45 minutes from this vista here, which is called Nachal Tzin, and it's just less than a 45-minute ride from Beersheba, and I suspect even today it's probably bright and sunny there. So thank you very much.